Welcome to the next webinar in the BHI Collaborative's Overcoming Obstacles series, Sustaining Behavioral Healthcare in Your Practice. This webinar is titled BHI in Action, Fostering Effective Health Plan Physician Partnerships. Before we get started, please note that this webinar is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. If you have questions or concerns, please send your inquiries to practice.sustainability@ama-assn.org. This series is a collective product of 8 of the nation's leading physician organizations dedicated to equipping physicians and their practices with the necessary knowledge to sustain a whole person integrated and equitable approach to physical, mental, and behavioral health care during the COVID-19 pandemic and beyond. This webinar will cover what makes an advantageous payer-partner relationship from both the health plan and practice perspectives. You will also hear from a practice what skills and key considerations are crucial to partnership success in behavioral health integration. And with that, I will turn the conversation over to Blue Cross Blue Shield of Michigan's Medical Director of Behavioral Health, Dr. William Beecroft, IHA's Associate Director of Behavioral Health, Kristen Spangler, and Associate Program Director of Ambulatory Medicine at St. Joseph Hospital and IHA Site Medical Director of Ames Center, Dr. Corey Dean.
Good morning. I'm William Beecroft, the Medical Director for Behavioral Health, Strategy and Planning for Blue Cross Blue Shield of Michigan. One of the things that we have really focused on is collaborative care. And here's a model of the collaborative care process. I know you've gone over this previously, but the biggest issue that's different with this in team medicine is the place of the psychiatric consultant and also the behavioral health care manager. The systemic review tool or registry is really a critical component of being able to coordinate between the whole team and primarily the psychiatric consultant, behavioral health case manager, and primary care physician or provider. The interactions with the member themselves and the things that can be done to be able to keep the member getting well and staying well on their course of wellness. We've also looked at a pediatric module that can be able to expand this to a different age group. And it is a bit more complex. The same core team is involved, but adding in a lot of coordination with the parents, family, caregivers, outside treating providers, and being able to get that information into the treatment team and coordinate that completely is really a major feature of this pediatric module that we've looked at. We focused on depression and anxiety, but also ADHD. And eventually, with experience, we'll look at even touching base into issues of feeding disorder and other behavioral issues that occur for pediatric age members. We really look at behavioral health as being a public health crisis currently, and we want to increase the access to care. It's not maybe direct access with the psychiatric consultant, but it is psychiatric influence on the management of those cases. And the primary care provider really has immediacy of access to the psychiatric consultative process and coordination with behavioral health providers that are treating their members even outside their own team. We're looking at really giving high value, appropriate care to people and being able to look at the specific behavioral health needs that go into their medical needs and providing the additional support that is really necessary for them to get truly, completely well. We also are looking at the issue of self-management tools and resources along the way. So we look at a process of the behavioral health integration that's population-focused, measurement-guided, and evidence-based. In medicine, you generally look at, for say, a diabetic, the A1C and how you're progressing, and if it's not progressing, you modify the protocol. Same happens with depression using a PHQ-9 or an anxiety disorder using a GAD-7 as a measurement-based tool that can help you to not only screen the population, but be able to move forward with seeing the benefits of your interventions that are going on. Or if they're not moving, being able to look at modifying the treatment options that may be available for those individuals. So what's the business case for coordinated care for behavioral health integration? Back in 2014, and this has been repeated, Milliman came out with a really significant study that looked at 14% of people with insurance that had a mental health condition or a substance use disorder condition. And in general, those members consumed roughly twice the amount of medical surgical spend in that population. Most of the spend was in facilities, hospital and emergency department utilization. So trying to be able to address the entire patient was really the obvious intervention. We saw this also in our data that roughly 23% of the population had either a primary or secondary behavioral health condition along with a medical condition, and they consumed well into the 48 to 50% of overall general medical spend. So pretty significant. The impact study, which was also a fairly large study over a long period of time, looked at roughly at $1,000 per year savings at the end of a 4-year period for people that were treated within the collaborative care process, but also probably by assumption, other behavioral health integration could be able to provide similar savings, probably not quite as much because it's not as vigorous a program as collaborative care is. So what are the barriers to implementation? Really, you have to have the administration of the plan be able to buy into the business case and its development. Configuration of the codes themselves and being able to make sure that they work within the systems that you have as a plan. Being able to educate the changes in a complex practice flow, team medicine, which is different than many providers have been educated in their training in residency and medical school. Setting fees to make them not so much profitable, but that there's a margin that makes sense for the practice to be able to make these changes, to change the expectations of patients and be able to move forward with this model. You can't do it without being able to have a balance and make the practices whole in this regard. And part of that is working with the patients themselves to eliminate barriers of copay, coinsurance, if at all possible, or to mitigate those costs. Patient selection is really important. If the patient's not ready or in a place to be able to work with this model, it won't work for them. And the patient registry is a difficulty, but it can be overcome. And many practices have been able to overcome the registry and functioning of the systemic review tool. Psychiatrist recruitment, we thought was going to be much more of a difficulty than what it has been. But that can be a barrier in certain areas. It can be done by teleconferencing. So that also eliminates a barrier there. An incorporation of the advice of the early adopters and partners like IHA, which I'll introduce in a couple minutes here, has really been significantly important for us. We've taken this to heart and really have looked at training up practices to be able to provide these services. We have 2 significant training partners, the University of Michigan and a group called MIXI, which is a group on the west side of the state, which is the Michigan Collaborative for Clinical Systems Improvement. And they work together with us to develop a curriculum for this. We've been able to incent the practices to close for a 2-day period of time for the intensive training and continue the training for up to a year on an ongoing basis to make sure that the practices stay on track. And if they need longer than that, we can even do that if we need to on a consulting basis. We provide a robust incentive for the provider participation itself, along with paying for the training. And then we continue to support with the ongoing education. And with that, we had roughly about 40 practices that were early adopters. Even before we started the first year, we trained up roughly 180 practices, including them, by August of 2020. Our 2021 goal was for 75 practices. We will exceed that at approximately 92 to 94 practices by the end of the year. And we will then be looking at another 125 practices in 2022 that we will train up. Now, this equates to 4 times that amount. So we're looking at roughly 350 practices, with some de novo practices also coming up without our training. And in those, we look at an average of 4 providers. So we will have trained between 1,200 and 1,400 providers in this model by the end of 2022, beginning of 2023. We do have the specialty specific curriculum of pediatrics, but we also have a couple other ones with substance use disorder, and also members with chronic mental illness in a module. And those are pilot programs, those last 2 that we're working on. So it's been a very significant process for us to be training these practices. We have the luxury of having been able to do that with practice transformations funds that we set aside years ago to be able to implement this. So how is it beneficial to our patients, our members? You really look at streamlining the approach to care. It's kind of a one-stop shopping. You get coordination between the various specialties. Many times we have these siloed practices, and outside services are really not communicated very effectively into the primary care practice. So it's really getting that communication really fine-tuned, and that functions to really help the patient to not have to be the vehicle in which they're telling the primary care doctor what the psychiatrist said, though that becomes quite common many times. It also maintains and leverages the patient's relationship with a trusted provider, which then helps to be able to eliminate the issue of need for additional outside appointments, and consequently reduces the stigma, because people don't know why they're coming to the primary care doctor for their diabetes, for their hypertension, for their depression. Nobody knows from the outside, so it decreases stigma and consequently improves access. As a psychiatrist, I was able to see and panelize with about 600 to 800 patients at any one point in time. With this model, the psychiatrist can have psychiatric influence on the care of roughly 2,500 patients. So it really significantly multiplies that psychiatric service provision in partnership with the primary care practice in the primary care setting. So what do you look for a practice that's ready to make this transition? That they believe coordinated care is a way to go, and to be able to look at people holistically and want to practice in a coordinated fashion. It eliminates that frustration of trying to find data of what's going on outside their practice. They already have it. That they're really treating the whole person, which then that can be helpful to get a sense that you're making progress for that person's quality of life and improve the outcomes, obviously, especially people that are at risk or pay for performance programs. This really makes a significant difference. And it makes it easier for members to receive care without the stigma and the other and improves the social determinants of health attention to that kind of a detail. So with that, our practice partner, IHA, they have been a provider that's had a long-standing partnership with Blue Cross Blue Shield of Michigan and Blue Care Network, thereby already eliminating the barriers for innovation of developing of that provider relationship. They have a history of treating patients as whole people. They have multiple specialties under one roof, and really significantly have eliminated the barriers of coordination. They text back and forth between specialties. If a person's in the hospital, the outpatient primary provider knows that they're in the hospital. He knows what's going on in the hospital, and they also know when they're discharged and when they're being followed up. That's an example. They focused on the ease of access, kind of one-stop shopping, and the need for a seamless transition of care between practices. And with that, I'll turn it over to the IHA.
Hi, I am Kristen Spangler. I'm the Associate Director for Behavioral Health at IHA. And I've partnered with Dr. Corey Dean for the 6.5 years that we've been doing collaborative care. Corey, did you want to introduce yourself?
Good morning. I'm Dr. Corey Dean. I'm the Associate Program Director of our Ambulatory Medicine Program at St. Joseph Hospital and the Site Medical Director for Academic Internal Medicine Center with IHA.
I thought I'd tell a little bit of the story of how IHA came to the collaborative care model. At IHA, there's a meeting every year where the providers, and now we include staff, and we vote on the priorities for the organization. So for years, improved behavioral health services were right at the top of that list. Typically, the first one was a great EMR, and then right below it was behavioral health. So this was something that the providers had asked for pretty loudly for years. So our executive leadership started researching models. They were looking for kind of what services were out there and what was going to really give the most bang for the buck, knowing that we can't help everyone. What's a way for us to help the most people or do the most good in behavioral health with the resources that we have? So we looked at that collaborative care model and determining that not only is that good for patients, but it's also the right level of care for our physician group. It's also the right level of care for our physician group. So in the beginning, the IHA executive leadership researched the models of behavioral health care. And once they'd committed to piloting collaborative care, they started to talk with payers about looking for support, specifically financially. Behavioral health integration was simultaneously a priority at Blue Cross Blue Shield of Michigan. So those initial discussions led to the start of a behavioral health integration work group that included an incentive for participation. IHA joined the BHI, the Behavioral Health Integration Incentive Group, offered by Blue Cross and Blue Shield of Michigan. And we participated in 3 annual cohorts in the beginning. So this was a forum for networking, access to the payer to help problem solve. It helped with accountability for timelines and outcomes. And there was an incentive payment for participation. We also had a grant from Blue Care Network in the early days that helped fund the work. The requirements of the incentive program aligned with our value of quality improvement. So I happened to find online from the first cohort the requirements, and it included identifying a quality problem, describing how we would collect data for a baseline, and then outlining a plan for collaboration, listing our goals, and a work plan to address that quality issue. Now, at the same time, we partnered with Michigan Medicine, who was launching collaborative care. You heard Dr. Beecroft mention that they've been a partner, and they started collaborative care about 6 months ahead of IHA and brought us on board. We partnered in our initial pilot, and they served as a consultant and collaborator. And this is at the clinic where Dr. Dean is the site medical director. So we'll talk some about that initial partnership. We shared in learning and in program evaluation and in troubleshooting. Let's flash forward about 6 years and several quality improvement cycles later. So we've identified core areas to supporting success and sustainability. We'll talk about each of these, and we'll see the times that our partnerships got us through. Some of those barriers that Dr. Beecroft mentioned were overcome because of teamwork and these partnerships. Now, Dr. Beecroft shared this structure with a similar graphic, and it's important because before you can start to support teamwork, you have to build a team. And ideally, we want a medical provider who believes in collaborative care. That was one of the points that Dr. Beecroft made as well, that belief that we can work as a team to treat a whole person. We're looking for a behavioral health specialist or a behavioral health care manager who is resourceful, passionate, and clinically nimble. And then a psychiatrist who's ready for that paradigm shift that relies on case presentation rather than direct evaluation. Dr. Beecroft talked about moving from seeing 500 patients on a panel to having that influence and support and connection to maybe 2,500 patients. And the most important part of the team, of course, is the patient. So the evidence supports that collaborative care is effective with patients who have uncomplicated depression and anxiety, and that the right level of care is the right thing to do for the patient. When we stray from the model, we stray from the evidence, and we do a disservice not only to the patient, but the behavioral health community at large. Corey, what's been your experience in building that collaborative care team?
Yeah, I thank you very much, Kristen, for that great intro to the program. One thing that I reflect on in this process of doing this for the past 6+ years is, what was it like before and what is it like now after? I recall, I just to give a little bit of background about myself, I see my patients in my own office that is connected with IHA, but I also lead our residency program, the AIM Center that we're kind of alluding to as the initial starting point. And when I recall my own experience and I observed the residents' experience, this has been a dramatic paradigm shift for us in a good way. Before, what do providers want? They want collaboration. And what is the big barrier? It's time restraints. And we have this very complex patient that walks into our office, and we have 15 or 20 minutes to take care of their concerns. And we run into that problem of, well, how do I manage this as a silo before behavioral health? And now when I look and I see how we've progressed, it's just a wonderful process to be able to have this partner, this team-based partnership with this group of providers that really helps to care for that patient. What happened before is that we would take extra time, we'd spend that extra 30 minutes with this patient that's having difficulty, and then we'd often have a gap where we wouldn't see them for maybe 3 or 4 weeks or 2 or 3 weeks. And now we've got a touch point with our behavioral health specialist and then the consultation with the psychiatrist to really stay in touch with that patient. The success rate obviously goes up tremendously with that type of program. I also always think about, we really want to know the data, data-driven evidence of why we do what we do. And when this model was developed, there was just wonderful data from the Washington model that came out that really spoke to how this can be implemented. But until you do it yourself, can you reproduce it? That's the big question. And what's been really remarkable about this program, as we'll see here in the future in the slides, is that the data speaks volumes about the benefit of this program. So I bet you, Kristen, you got a few things you want to say about that, don't you?
I appreciate you teeing that up. I do have some slides and comments about gathering the data and also presenting it. To start off, before we even get to the data, we need to get this team working together. And so the buy-in from the team, and especially the providers like Dr. Dean, needs constant nurturing for the collaborative care to thrive. And I don't mean that Dr. Dean needs the nurturing, but in general, that relationship. So one way we achieve this is by ensuring that we provide value and make the PCP job better for our providers. It's sometimes difficult to balance the accessibility and visibility with the need for appropriate space for that behavioral health specialist, behavioral health care manager, since they're also providing clinical care. So ideally, we want that workspace to be centrally located and also some semi-private. So if it has to be a shared space, we're just flexible in finding a spot for the behavioral health specialist to work with their patients one-on-one. But if the behavioral health specialist is not accessible or easy, then the program's going to fail, because this behavioral health care manager is not just the face of the program, but when they're the only person in the office that is the collaborative care service team lead, they're the whole program. We've also found it valuable to provide limited consultation outside of enrolling patients into collaborative care. Since the evidence doesn't support that all mental health populations benefit from co-care, we invite our providers to reach out for one-time medication questions, suicide risk assessments, discussion of differential diagnosis, and active management to a higher level of care. For the curbsides that require input from our consulting psychiatrist, the behavioral health specialist acts as that liaison. We also keep the team apprised of the collaborative care impact, because that supports buy-in. Our behavioral health specialist attends provider and staff meetings, shares success stories, and the results of quality initiatives, especially if they result in workflow changes that affect the team. We also share high-level financials, such as the value-based reimbursement that we receive from Blue Cross Blue Shield of Michigan to do this work. So one other value-based service we bring to the office is education opportunities, either at a specific meeting or as a part of regularly scheduled provider meetings. Our behavioral health specialist and consulting psychiatrist partner to deliver a lecture on behavioral health topics. So on a larger scale, we've also done division meetings, grand rounds, educational conferences for residents on behavioral health topics, such as diagnosing and treating depression and anxiety, bipolar care, insomnia, ADHD, working with challenging patients, geriatric depression care, cannabis, firearm safety for primary care, illness anxiety, and suicide assessment. Corey, what could you tell us from a provider perspective regarding accessibility and communication?
I think it's just very important for this program to be embedded in the office. That warm handoff that patients get is critical to that establishing of a relationship, getting a good plan about the follow-up. Often, personally and with my residents, when I'm training my residents, I'll talk to them about, hey, let's go talk to our behavioral health care manager and let's have a warm handoff and introducing them to the patient. They know the doctor, they know the resident physician or myself, but they may not know this person that's giving them a cold call later on to kind of follow up on them. And having that warm handoff with that embedded process is critical. I would also speak to the education part. We've been so blessed to have this team come and educate our residents and educate us as faculty. It's been amazing to have these talks that Kristen alluded to that really helps us all to kind of come together on a unified treatment protocol and get our psychiatrist, in our case, Dr. Ryan, who's just been a fabulous resource for us to come in and educate all of our residents and faculty. This process has been instrumental to a lot of our ability to have great care for our mental health needs within our office. And I also add this, even when it goes beyond the model, there's, the anxiety and depression that we're talking about. This behavioral health care manager in our current process has been equipped with tools to be able to help refer out in those other really complex situations to help our patients as well. These things are invaluable for our patients and for our physicians together.
So not surprisingly, the financial piece is critical to sustaining the co-care work. And you'll see how joining with Blue Cross Blue Shield of Michigan has furthered our work. Using the co-care CPT codes, that's 99492, 99493, 99494, 99484, and G2214. Those have specific requirements. So Blue Cross was one of the first commercial payers to reimburse for these codes. And at IHA, we work with our compliance department to ensure that we're meeting the billing rules. And I found it helpful to partner with a contact in compliance so that we can learn from each other. And when there's a question about requirements due to vague wording or the billing rules, we've been able to work with Blue Cross to address that obstacle. And because we've established our fidelity to the model and we've demonstrated our outcomes, Blue Cross values our input. Where it was gray or unclear about billing expectations, we were able to have a discussion about the spirit of the work and the intention to deliver the service in line with the model and the evidence. And it was productive in a bi-directional way. Like, we gave information, we received information, and Blue Cross was a significant partner in helping us overcome some of those barriers. We were able to build a table in our EMR that collects the minutes for co-care. So these co-care billing codes are based on minutes in a calendar month. And we developed a report that adds them up. And I still double check those documents to make sure that our billing matches what is documented in our record. Thank you, compliance, for making sure that I stay out of jail. And if you've got a registry, which is one of the components required in collaborative care that keeps track of those minutes for billing, the double documenting that might be required, it has been worth it in our case to help us audit our process and also identify opportunities for being efficient. Revenue teams in our organization have been able to rectify charges that were denied in error. And Blue Cross has been able to work with us troubleshooting on their end as well. Billing and revenue was a top topic at those quarterly Blue Cross Blue Shield of Michigan behavioral health integration cohort meetings. So we worked together to demonstrate the value of the work and the need for using the BHI codes to support it. There was discussion about using other codes, and Blue Cross Blue Shield of Michigan listened to those of us doing the work. Because we regularly connect with other teams doing the work, some of the patterns of denials got strength of numbers, and we were effective in getting payers to improve their system. And in some cases, getting collaborative care codes turned on as a benefit. In addition to that macro work, having a connection through the BHA process has given IHA an avenue for individual patient and member troubleshooting regarding billing. So we've worked together on these cases, and the patient was served as well as the greater good as a team, because as a team, we can identify snags and address system issues. All right, here's where I start talking about the data. I'm a huge advocate of tracking progress as well as outcomes. I'm sure we've all been in situations where we thought we were doing well or where we thought we needed to better, but without that data to inform the situation, we're just guessing. And we might think that something is a success because we feel that it is, and data will help support that. A patient reports satisfying family relationships. Another patient stops taking benzodiazepines. And these are successes. And they're part of the story. We want more of the story, something that is more comprehensive. So we look for data that supports it. Where did we start? Just because you can measure something doesn't mean that there's value in doing so. We want both process and outcome. Think about the essential elements of co-care. What can you measure that aligns with those aspects? Pick a few, not all. And in our case, we measure our monthly enrollments because we want to know how many patients we're serving. We track rates of implementation of psychiatric recommendations because that's a core service of co-care. And we track changes in PHQ-9 and GAD-7 scores because those reflect improvement in mental health conditions. And as I mentioned before, we take account of our program as a whole across all the offices and at the office level individually, remembering that factors in one community or office might mean that their patients and outcomes are going to have their own benchmarks. And in addition to these qualitative data, we also survey our patients and providers regarding their co-care experience, because the data is always stronger with stories, and the stories are always stronger with data. We encourage our behavioral health specialists to write up a success story each quarter so that they always have a new story to share with their primary care teams. Corey, how has the data kept you engaged?
Yeah, I think it's been very important. In a residency program, we speak about evidence-based medicine all the time, and this is another good example of that. I think that for buy-in for physicians, they have to see that it's working. More importantly, our patients also deserve that. For us to invest a lot of resources like what, Blue Cross Blue Shield has spoken about, we want to invest in things that are really going to actually make a difference for our patient. We want to choose wisely. And I think that in this process of getting that data, it just validates what we feel, what we kind of know. And so I think that it's been very helpful to share that data with our physicians, our staff, our whole team to, again, really have everybody on board with why this is so important. And I think sharing that with the patients too. I know that this data, may not get out to the patients as much, but letting them know that this is really making a difference when that GAD-7 score and that PHQ-9 score drops down by 5 points or more. They feel that too. They know that.
Yeah, we've shared our outcomes with Blue Cross Blue Shield of Michigan at those quarterly BHA cohorts, as well as for ad hoc situations. So both our process and our outcomes helped shape expectations for the next phases of the incentives that Blue Cross has offered. So I'll quickly move through a little bit of how we present our outcomes I like to use very simple pie charts so that they show the story, even if you didn't have the numbers. And this helps our stakeholders see the changes. So we use this for various stakeholders and communicating that we are getting patients better. We also poll our patients. As I indicated, we have patient surveys. So these are actual patient comments that really put real life situations with those numbers from the GAD and PHQ score changes. So going from a PHQ 9 score of a 15 down to a 4, or a GAD 7 score from a 20 to a 10 has meaning in the numbers, and it has meaning in these life experiences. I want to leave you with some kind of pearls that I want to string together. And that's that our team is all in when it comes to collaborative care. It's not hyperbole when I tell everyone that I can that collaborative care is a game changer for patients, providers, and society. So as you embark on your own efforts to stand up successful co-care programs, I'd leave you with a few thoughts about the work. Practice fidelity to the model because that's where the evidence is. Don't quit. You will hit roadblocks and have trouble seeing your way through to the other side, but please keep going. Embrace your team as the only way co-care will thrive. You all need each other and you all have pieces of the puzzle. Use your resources, Blue Cross, the University of Washington, the APA. Gather data and remember that your outcomes are not the complete answer. Patient and provider subjective experience is important too. Some things can't be measured. And you're going to have to roll with it when things change. Think back to when we all learned how to work from home in one day. If you remember the spirit and the mission of co-care, you can find a way to adapt when needed. Remember to check with compliance. Along the way, we've had connections that were thought partners as well as financial backers. Our partnership with Blue Cross helped us sustain the program financially and introduce us to others doing the same work. We had the opportunity to help shape expectations. When I think about the successes we had in our relationship with Blue Cross, 3 things come to mind. One was that first step, reaching out to the payer to start conversations. Both physician organizations and payers have ideas about addressing behavioral health, and we found common interest and common ground. And as we did the work, we saw the impact on patients as well as providers, and sharing our successes and challenges with Blue Cross provided value and opened opportunities. For us, we demonstrated that we were helping patients get better, which is common ground, and we had evidence to back that up. By sharing challenges, we relayed the real world difficulties, demonstrated our commitment to overcoming them, and created an opportunity for the payer to be creative and part of the solution. And above all, nurturing a relationship builds trust and reliance. From my perspective, I have a contact when payer issues come up. I'm also happy to answer questions about how the work happens. We're a resource for Blue Cross, not only for particular questions, but as a presenter to broader audiences. Blue Cross helps fund our work and looks for ways to make it easier for patients to participate. It's better for the patients when we work together. Sam, I believe you have some closing thoughts.
Great. Thank you so much, Kristen. Thank you, Dr. Beecroft, Kristen, and Dr. Dean for sharing your expertise and experience with our viewers today. Be sure to visit our series page on the AMA website for more information on upcoming releases. You can also access previous recordings on our YouTube playlist. Please also check out the Collaboratives resource, the BHI Compendium, for a helpful framework on how you can make BHI effective in your practice. Thank you for joining us today.